When I was trained as a pediatrician, which was not that long ago, I gave that advice to parents. For those in high-risk families where either the mother or the father had allergic rhinitis, asthma, some other atopic disease, and especially if the baby had any signs like eczema or something like that, we advised waiting until the age of 3 to introduce things that we thought would be allergenic, like nuts or shellfish. And we also recommended, delaying milk until age 1, eggs until age 2, and then nuts and fish and shellfish until age 3. The idea there was that there was some sort of susceptibility early in life where the immune system was maturing, and if you withheld exposure to allergen during that susceptibility period, and then it closed, and then you introduced allergen, you had a lower risk of having allergy. I think we can conclusively say that that way of thinking is now outdated. We sort of reject that idea. The current weaning guidelines, the current guidelines from the American Academy of Pediatrics and other organizations have revised the recommendations. So we no longer say wait until age 3. But we have not been able to more forcefully say you should introduce foods early because it is preventative on the basis of well-done studies. And I think that practice is sort of an evolving enterprise. So in our study, and conventionally in most immunotherapy studies, participants are excluded if they've had a history of essentially a life-threatening peanut reaction. Okay, so we're talking about somebody who is having unstable blood pressures, who may lose consciousness, who may be admitted to the hospital and even to the intensive care unit for severe anaphylaxis. Okay, a participant like that would be excluded from the study. In reality, we don't encounter patients like that routinely, at least among those that we screen for our studies. So we actually don't. One question I commonly get when I present my results is, are really severe patients included? And the truth is we really don't turn many people away from the studies. That's a safety issue to be sure that when we study immunotherapy, we don't harm people. But as it pertains to how do our findings apply to the general population, the truth is virtually all patients with all types of peanut allergy are included in our studies. I'd say we don't have the silver bullet to say this explains the change. And my bias is to say that there probably is no silver bullet. My guess is that there are a number of factors that work, in concert, that each of which explains a little incremental increase, and which together help explain this massive shift that we've seen. I think what we can say is that although the tendency to have allergies is largely inherited, it's well established and long understood that allergies run in families, and so there is a genetic or heritability component to it. What we've seen with food allergy in our generation has occurred much more rapidly than can be explained by genetics alone. And certainly there are children diagnosed who don't appear to have genetic risk. And that means that there are environmental components that are key factors in driving a lot of this allergic increase. Some of which may be as simple as people presenting to the doctor to be tested more often because of more awareness. And then many of them are almost certainly biological influences, ranging from the types of reduced microbial exposure referred to as the hygiene hypothesis, to changes in the bacteria that live on our skin and in our guts, et cetera. So I think there's probably a wide range of potential explanations, again, all of which in sum contribute to this real change over time. Allergies certainly follow ingestion patterns. And when you look around the world, places where people are exposed to foods that would be considered relatively unique here, you see more allergies. So it changes based on exposure. And so, for example, in Europe, there has been a much bigger problem with certain allergenic seeds like sesame seed and mustard, where they see anaphylaxis to these seeds. We don't see as much of that here. although we're starting to. So a lot of it relates to exposure patterns. I will say, in particular, with respect to the case of peanut, it's interesting. Most of the exposure that happens in the U.S. is to roasted peanut, dry roasted peanut, whereas exposure to peanut in other places is often boiled or fried or raw and not dry roasted. So, for example, Southeastern Asian countries use a ton of peanut in their cooking. People are exposed regularly, but you don't see a lot of peanut allergy. And those exposures are typically not to dry roasted peanut. We understand that the processing that happens during the roasting process actually makes them more allergenic.